from Suso.
Uh,
Don't know, but so for those of you who are new to and haven't attended a CMIT meeting before, this is a um through our GWEP grant, this is sort of an expansion of a long-running interprofessional team that is a collaboration between the Area Agency on Aging and clinicians at Suma Health. So historically, what would happen was geriatrician and pharmacists from Suma would physically go over to the area agency where their care managers would bring in cases that they were just having questions about, or maybe just wanted reassurance that they're doing everything that they could. And so the whole team, it was a room full of people, would sit around and sort of brainstorm about problems. And, it's results in, better, you know, care for people, basically, with the overall goal of keeping people living in their homes for as long as possible. So this with our GWEP again is an expansion of that. So using it really for educational purposes too. So who we have on the screen today. So Dr. Sibley Strader is with Asia Services in Action in Akron, right across the expressway from Suma Health. So she's going to be presenting a case today. We have Dr. Jennifer Drost from Suma, who is a geriatrician and part of the GWEP team. Myself, Michelle Guerreri, and Denise are all part of the GWEP team too. Stephanie, you want to just introduce yourself briefly and where you're from?
Hi, I'm Stephanie Sanders. I'm from Community Support Services and work with geriatric population with severe persistent mental illness.
Danielle Walker?
Yes, I am a case manager with Signature Health for geriatrics.
Yay, and I'm Signature Health.
And then Ryan?
Yeah, my name's Brian Cook. I work at the University of Mount Union as well as work in a private practice, and I do counseling.
Great. Thank you, guys. All right. So, and Lori Warren just joined us. Lori, introduce yourself. So Lori is with probate court in Akron, so she joins us for that side. That brings that perspective to our team. So I'm going to go ahead and turn it over to Sibley to present our case.
Thank you so much. Good morning. This is Dr. Strader, and today's case is a 67-year-old male. This case is more clinical. There are psychosocial components, but I chose this case because 80% of my geriatric patients have one part of this challenges or the other. But let's see. So this patient is a 67-year-old male. He is from Bhutan from 2016. He is divorced. His children is still in Bhutan. He lived with his cousin. I have it in parentheses because my patients use cousin and brother and close friends and neighbors interchangeably. I think this patient is not related to the person he is living with, who is helping him make healthcare decisions, because he doesn't have other people here to help him. So he lived with his cousin's wife, and his cousin's three kids. He has one brother and two sisters. I think they're in Iowa. He left his family to come here because he couldn't get along with them. And then he has a son and daughter in Bhutan. Can I see the diagnosis? please. Okay. I'm going from bottom to top because this is the timeline of when his problems are diagnosed. So in 2016 to 2021, in that 5 years, he saw 3 providers from my clinic. 2 are botanists to actually speak his language, and he has in plenty of concerns to start. So from 2016 to 2020, he was diagnosed with insomnia, anorexia, hypertension, depression with history of suicidal intense ideation. He can't see very well, can't hear very well, and then he was treated with LTBI. And then in 2020, he went to Western Reserve for a left knee injury and find out he has a left medial meniscus tear. And then he did not follow up with ortho until 2021, a year later. In 2020, he also started complaining of back pain and he was diagnosed with arthritis. And he started seeing his PCP gave him a diagnosis of mild cognitive impairment, and he finally sees psychiatrist at that time and find out he has alcohol use disorder. In July 2023, that's when I first saw him. He already have pretty advanced cirrhosis. And then 2023 November, that's when everything went terrible. He got cholecystitis. He has incidental finding on the ultrasound for the cholecystitis, and then esophageal mass from an endoscopy, and then he also then endoscopy find out he has H. pylori. The prostatomegaly, I will explain why I added it, and then he was diagnosed with cancer December 7th. And now he's on chemo, 2 months, 2 rounds of chemo and radiation. May I see the medication? Danielle, may I see the medication? Sorry,
I
Danielle?
put it on that cake.
Okay.
Can you see
I
it?
I see half of it. It's not scrolled down all the way. Oh, thank you. So the one on the left are the medicine he took before. The one on the right is added by oncology, and I have only seen him once. This medicine hasn't been adjusted, and nobody is managing this medicine right now. So he was on Tylenol, amlodipine, Lipitor, vitamin D, and then ointment, gabapentin 3 times a day, folate, and then Claritin, more blood pressure medicine, and then calcium and vitamin D, and then thiamine. So he has B1 and B12. And then when he went to Suma, actually, big shout out to Suma. He's getting really good care with Suma, and then the oncology social worker is helping him right now. His new medicine is the vitamin and Zofran, protonics, and more vitamin D. This pharmacy, they don't usually check. Usually clients and Best Care, another pharmacy, would call me and let me know patients are on twice as many medicine. But I think they just give him vitamin D 400 unit, more vitamin D 400 unit, and then the vitamin D combination with the calcium. And for his pain and nausea, he has viscous lidocaine, he has compazine, he's getting ultra. I can't see from Care Everywhere how often. He's getting it from one pharmacy, Lifeline, and then he's getting oxycodone solution from CVS. And functional status, he needs help with his he does need help with his ADL and IADL. He does have home care and physical impairments. So if you can scroll down, he can walk fine since even the last time I saw him. And then he wants wheelchair, bed, and commode in the last appointment. Um, so mental impairments, he does have mild cognitive impairment, but me and the palliative doctor saw him at the hospital. He knows place, persons, maybe not dates. He can repeat to you what he can repeat to me what I tell him. He can make some decisions, like he can tell you he knows cancer is bad for him and drinking is bad for him, and medicine is good for him, but not much more. He never really have any hospital stay. He was only seen in Western Reserve last year because he's fallen and because he was intoxicated, and then he had a cut on his head with 10 staples. Well, and my primary issues of concern is I feel helpless and I feel guilty because it takes 5 months for me to get to this diagnosis. And this timeline is very typical of my patients. Um, and when it comes together, it doesn't look that bad, but like it takes so long. Like I keep thinking, if we find it faster, would it have been better? Um, and if there is anybody else who could have helped me get to this. The primary challenge, of course, he usually comes in by himself. So mild cognitive impairment, he can tell me he's taking medicine and he can tell me that he's going to appointments. He needs help with some other things. He came in once or twice, but both times with different family members. So also typical of my patients, and all the complicated medical conditions. I keep explaining it to different people, and palliative care also the same. For some reason, patient's family always think patients are doing better, and every time is a new discussion with somebody else, and sometimes they don't talk to each other. Um, and then sometimes patient comes in and he may be a little intoxicated and he will wander around in the clinic and the MAs bring him back to the room. Now, I first met, so the patient's been in my clinic since 2020, but his last PCP left, so I got his care transfer in June last year, and he has calves pain for after a long travel. So that day there was a big concern with DVT, and then he needs leg ultrasound. And then in July he came back again. The ultrasound was negative. He feels better. That's when he first talked about the solid food dysphagia and the weight loss and weakness. Um, the referral was sent and he got a GI appointment in September, which is also typical for my patients. And then he doesn't know how to call back, and then let's see, August, I see him once. At the end of August, I see him once before the GI appointment, and I make sure that he goes to his GI appointment. And then after the GI appointment, the specialist or the EGD and ultrasound, but he didn't call for the referral, and I didn't have a chance to. I don't have a slot open for patient follow-up. So on October 31st, the SUMA specialist called, SUMA's specialist staff, the GI staff called him to try to make an appointment, but then nobody answered. And then November 8th, they came to my office. The patient still feels the same. So I called when he was in the office with me to schedule the EGD. And then the Nepali referral staff came in to talk to the patients, called to talk to the brother, and we print out the paper for him to take home. November 15, the patient went to GI, but GI couldn't help him with anything because there is no endoscopy and there is no ultrasound. And he finally got the EGD November 29th, and then December 7th, he got the cancer diagnosis. And then December 13th, he got the PICC line and he has a PEC tube now. And then he started radiation. I don't know if this is palliative radiation or if they're trying to treat him. And then, of course, like I have only seen him once. Where do I go from here? What kind of help can I get him? I know the SUMA special social worker. She is awesome. She helps him get his supply. She visits him every time he goes to get radiation. But there is like nothing I can do. I can think of from my side. And then I feel like I'm out of the loop because from the November 8th appointment, I didn't get any notice. The only thing I left it on there is a CT that is a CT that he has enlarged prostate. And I didn't look at the CT closely because I feel like in my mind, like enlarged prostate is not that important. And then they didn't talk about anything else. And then December 18th, that was when I first find out that he has cancer and he already had the PICC line, he has the G tube, gastric tube, and he already started radiation. And I signed a request for hospital bed, and I faxed it back, but there were a problem. And then I got COVID and I was sick. And then no January 2nd, patient met with Nicole when they first find out they need everything. Actually, for number 4, January 10th was the first time I saw him, and they were on the way to chemo. So the appointment was Sibley, I am going to chemo. I have 15 minutes here. I don't get to talk a lot, but I need a bed. I need Oh no, that brother says, actually, I have to go in 15 minutes to make it to chemo. I can't talk real fast, but I need a bed. I may need other stuff. Get me everything you can. Um, so that's it. That's my case. Um, um, is there any questions or anybody need clarification?
I have a question.
Uh-huh.
Does the patient have like a guardian or somebody like that?
Not yet. So this patient, because no, he doesn't have one, and there is no chance to work on one either. Because up to the cancer diagnosis, he can make some decisions, and even when he was in the hospital, palliative care went to visit him and had a long, the doctor thought meaningful conversation with him. And then the doctor asked the nurse to call when the brother showed up. And then the palliative care doctor never get to see the brother because the brother didn't want to meet. And then he also tried to call family at home and nobody answered. And that was one of the things I wasn't very happy. I say happy. It was one of the things I was unhappy about too. Um, none of, and he doesn't really have family. No family ever showed up with him to the appointments. And then all of a sudden, his cousin shows up and asks for 100 things in 1 week, and then and then get upset because I cannot get it for them right away. Yes, so getting guardians may be challenging also.
Yeah, I think that's actually from my standpoint, one of the biggest concerns, right? Like is who eventually and what, right? Like I agree. I think kind of in in that conversation, a guardian is probably not appropriate for him at this time. But the challenge is like if there's not somebody who is willing to be engaged, then eventually that may be what needs to happen. So I think a lot of conversation and maybe following up with the palliative care clinic, if that's a challenge to have there in the in your office, Sibley, on the importance of healthcare power of attorney, because that's really what he needs. And then, somebody, and hopefully that person is somebody who is willing to be engaged in the ongoing conversations, and that he's allows that person to be engaged in the ongoing conversations, because it does sound like that's where a lot of that gap is. And unfortunately, for one reason or another, and this may be, all kinds of reasons, I suppose, from the patient's cousin that he lives with, that might not be the right person. I don't know if in November when they called the brother, like, is that actually the patient's brother that lives out of state, or was that the cousin still for that?
That was the cousin. He doesn't get along with his brother out of state, and then he lived with this cousin, and this cousin has actually been doing all the interpretation for him, taking him to all the appointments, and asking for DME and um, everything on his behalf.
Oh, but then didn't want to talk to the team when he came to the hospital?
The team is awesome, but I look at the notes. It looks like the cousin, he called himself the brother. He has been declining interpreter. And then I can see why, like even with interpreter, the patients may say, I'm fine. You can talk to my cousin. And then the cousin talks.
Oh, okay. Sorry, I missed that, I guess, a little bit there from the standpoint of trying to, right, have somebody engaged and officially like completing those like healthcare power of attorney documents from that standpoint. Certainly it is hard. People can unfortunately tell you whatever they want to tell you, and in some points we have to, just kind of accept if they're not budging off the I'm fine or I'm better, or that sort of conversation. I think that's is very hard when working with people, and a lot of these symptoms are very subjective. But I think that especially with kind of the waxing and waning mental status that he's had in the past, that's particularly important to shore up that documentation for him, because otherwise it will be the brother that he doesn't get along with, and we don't want that either. If that's not what he wants, I suppose.
Thank you. Oh, and he still have a lot of appointment lined up. He has appointment with me in March. He again, Suma is wonderful. He has a palliative care appointment coming up in March also.
Okay. It feels like that should be longer than it is from now, but I guess that's only a couple of weeks.
Um, like everything to me, like this is a really typical timeline for me to make referral for patients, but I don't know if there's any, like from 2000, when he told me in July, he said he already had symptoms for 6 months, and then it takes him 5 months to actually get the diagnosis. And I feel like maybe from 2020 to like 2024, there was something we could have done, and there is something missing, maybe from the clinical side or from the psychosocial side, but I can't think of anything that would have made this a little better.
Yeah, that's real hard. and I, you know, on both this side and then, you know, personally, right? Like once she kind of, actually, once he got the diagnosis, everything moved real fast. Like getting that
Yeah,
diagnosis to begin with.
you're right. Um, I I I became a PCP. Like I see this a lot. Once it's happened, then it's a whirlwind of interventions, and then the patient doesn't really have a lot of time to decide what he wants and what he doesn't want, and that was what I wanted to prevent. But you're right. I think it may be inevitable. Um, and then also the since substance use is a big discussion too, it takes him, like um he does have a lot of health problems, but it always frustrates me that he has many caring doctors that actually speak his language, and it takes us what 2 years or 3 years to find out that he has alcohol use disorder, and then the thiamine and the folate doesn't start, I think, until he talked to the psychiatrist. And I don't know how we can like screen for that when he has other medical concern too.
Did anyone simply ask him about his alcohol and drug use?
Yes, we do have the PHQ2 screening, like our Nepali staff do the what's that, the 2 or 3 question screening, the single question screening. And then most of the time he said, I'm fine, but I can't see, I can't hear, and my stomach hurts a lot, which probably is from the drinking, and I have a headache. So for a few years there was the single alcohol use questions, and he was negative every time, and somehow he actually fooled to like really good Nepali doctor, and then he didn't find out till he talks to the psychiatrist. And I should have looked closer to the psychiatrist's notes. Maybe he didn't even answer the question. Maybe the psychiatrist is just running the panel of tests he usually runs, and then the GGT, and then one of the markers come up high.
Yeah. Again, sometimes like that's just the challenge of, I think, working with people. I think it's great, right? Like normalizing those questions in the assessment so that you do, as kind of Stephanie was alluding, like you just ask those questions routinely. You know, I wonder if there's you know, non-judgmental like literature or posters or like other things that can be displayed in office spaces that acknowledges that many people struggle with this. It can have a lot of health outcomes. If this is something you're worried about, or others have mentioned to you, we want to talk to you. You know, maybe that something like that can move people along that, you know, pre-contemplative to, you know, or not even pre-contemplative. There's something like totally not contemplative to pre-contemplative to like contemplative, like track of like, this is something that, you know, I'm worried about. And yes, it's frustrating. I don't want to minimize it at all. At the same time, I guess I hear a lot of that, like, I wish I could, I wish I could, I wish I could. And yes, that could have certainly had a very different outcome for him if, you know, even 6 months ago or a year ago or 2 years ago, right? Like this was identified at a different point in his severity. But
What is the cultural stigma or viewpoint of alcoholism in the Bhutanese population? I'm not familiar.
Oh, similar to in US, it's just shameful. No, actually, for my geriatric populations, not the Nepali population as a whole, they just think it's normal, like people drink. Then if the children don't give the parents anything to drink, then their friends would come over and bring them alcohol, and they make their own alcohol at home. In this case, even in December, when patient was getting ready to get the pet to put in, his brother asked the doctor if he can still drink some. And I don't know if it's because like they still want the patients to have some alcohol, or if the brother is worried a little about DT. That's a lot of my children, like the children of my geriatric patients, have that problem. Like they cannot help their parents stop drinking because somehow their parents can find it somewhere.
You guys, I mean, I know you have the psychiatrist. Is there anybody specifically around substance abuse?
Now we have a navigator. Before we didn't. And Dr. Drosh, you're right. We haven't thought of having poster outside. We have posters for gambling and human trafficking, but we don't have any alcohol use or tobacco use poster yet. So that's a really great thing to do.
There's that simple cage screening tool. Have you ever tried to cut down eye opener, that one, which would be a very simple 4-question, just to even address, approach the topic. I love the idea of the poster. There's some great posters on just the effects of alcohol on the body, on organs, just very simple, non-judgmental, just educational.
Yeah, it sounds like, if he's not divulging that he's drinking, I mean, there would be little to trigger you to do the cage until maybe you saw that those liver enzymes are elevated and things like that, which sounds like is kind of what happened. So, I mean, it's hard to kick yourself because it happens often, right? Like you have to rely on what they're telling you. So there is no test at this point other than the elevated liver enzymes at the point of damage.
Those who abuse alcohol are really good at hiding it.
Thank you. Thank you for the reassurance and the empathy from everybody. It's comforting to know, like, it's just comforting to hear from all of you that you feel the same way.
And I would add, right, like, your comment on, once the diagnosis, it's a whirlwind, and it is. And I'm sure for a lot of people, particularly if we're dealing with folks who have a limited health literacy, it really feels like through that process, I have no, right, like I have no other option. This is what I have to do. This is what they're telling me, and don't even have the time to like actually sit and talk about what that diagnosis means, probably in a way that is really understood. So I do think there's a lot of merit too, and you don't want to like freak people out necessarily, but like even in those referrals, with his dysphagia, weight loss, like I'm sure it's going through your head like, oh, there's something going on here, or there's at least there's a potential that something's going on here. That's, I kind of say big, bad, and scary for people. So even early in that process, like giving people that like warning, like I really, this could just be in, right, this could just be indigestion. This could be just the H. pylori, right? Like these symptoms can line up with that sort of thing. But I want you to go to see the specialist, and it's important you follow up with their recommendations, because this could be something big, bad, or scary like cancer. And if it is, the sooner we find it, the sooner we can start treatment to prevent it from spreading, because cancers, particularly in the GI tract, right, can spread quickly and can kill you. Maybe a little less blunt there in the end, but starting that conversation early with the referral, with the testing, maybe can help with that buy-in, even for the importance of getting that scheduled quickly, because I think that's really where the biggest gap was between that first appointment and when that EGD actually happened. And maybe that was because it didn't really understand why it was so important.
You're absolutely right, Dr. Strauss. And I usually don't want to scare my geriatric patients, but from now on, I will let them know. And it is better for me to be to be honest upfront, so then they will know the urgency instead of like thinking I'm protecting them or not scaring them.
What stage is the cancer? Like, what's his prognosis looking like?
I sorry, I tried to find it. I couldn't see it last night, and I I don't know, maybe I don't have access to the notes. I think it has not spread yet, so that may translate to a stage 1 or stage 2.
Yeah, points to a bigger problem with the health system in general, right? Is the inability of people to communicate, right? For all providers to be on the same page as what's going on.
Yeah, and I didn't and partially it's because I don't have a nurse anymore. I really didn't know he was diagnosed until after all the treatment started. But I did know he has enlarged prostate, and the doctor wants me to follow up with him on that.
It's crazy to think that, you're the primary caregiver and that you're not in that loop.
Yes, and I talked about it before. So like the best thing always to do is just a referral to the PCP for a referral for the PCP in the system, which I really love that. And I also feel bad that like if they want better care, they're not gonna like get it from my clinic because we have these challenges. But then on the other hand, if the patients do get good care from other PCP, I will be very happy too. I apologize. Once in a while, I give like really clinically focused case. I was gonna see if there is any idea from the community health supporter from the other team member. See if there's anything we could have done in this 5 years, like any referral or any social support I can get. Let's see, because I know the now worker, she's from community service.
Oh yeah.
I'm sorry, I'm from behavioral health.
Oh, wonderful. Do you have any input? I um I I look up to our behavioral health staff. When I was training in SUMA, the behavioral assess behavior is 90% of the patient treatment because doctors can give them all the treatment like recommendations and medications, but if the patients don't take it, then it really doesn't help.
Yeah, I unfortunately do have a current client who is not medication compliant because she says that she doesn't think that she needs the medication, but then when she doesn't take it, her depression, anxiety gets really, really bad. So yeah, we're struggling with that right now.
That's just normal. That's part of the, you know, the continuation of acceptance of illnesses. If I didn't think I had diabetes, I wouldn't be taking insulin either. So it's just kind of meeting them where they are, establishing that relationship, maybe kind of exploring the pros and cons of taking the medicine. Could it help? Could it not help? I don't know. And there's always the Alcohol, Drug, and Mental Health Board hotline, helpline, not hotline, for alcohol and drug issues or other concerns.
I guess something that, I'm sorry. I guess something that I would add. So my background is I work a lot with mental health. And as we were talking, I think something that stands out to me in particular, at different points in our life, as we deal with some of these issues and life changes, I think one of the big things we always notice too is that when somebody gets and has all of this physical medical care that they're going through, and it should be, there's this really important focus on trying to help them get physically healthy. I think sometimes that part of really helping them process mentally, emotionally what's going on, and having either someone to do that with, or even just as that provider of being able to be comfortable and okay with asking those questions, or encouraging them, or even normalizing, like you said, when you get these diagnoses, that you're going to have a lot of these emotions, you're going to have a lot of these thoughts, and if those aren't addressed, that can keep them from engaging in their care. And I think as mentioned, that if you can help them recognize they're going to have these thoughts, they're going to have these fears, or even these concerns, like, do I need to do this treatment, do I need this medication, of just helping them be able to make that choice of, this could be really beneficial for me. Because I think a lot of it is it's long-term care. And if they're not mentally, emotionally engaged in that long-term care, things just deteriorate quickly. And I say it even as a mental health provider, the number one person that they will go to is their primary care physician, the primary care provider. And that puts a lot of pressure, on you guys, because they're looking for all of that advice, and being able to connect to either those mental health providers, those psychologists or psychiatrists, that, that they can also provide that support for you. When I've worked in the hospitals in the past, I think we always said it's a major treatment team to help somebody through some of these things.
Thank you so much, Ryan. That's very, very insightful.
But no, I think you're doing good work with them, and as you said, just getting connected to some of those resources of what might help him right now. Because it sounds like he's having some engagement with the process, and he's getting good care. And on my side, I'm wondering, where's he at mentally, emotionally with it? Is he at the point where he's starting to kind of give up, or is he at the point where he wants to get better? And that's something that, from that mental health provider, would be curious to see, where he's at in that process.
I will be sure to ask about that first the next time I see him, and then also address guardianship.
Power of attorney.
Sorry, power of attorney.
Yeah.
Thanks.
And just right, like a note, the power of attorney doesn't have to be notarized. It can be witnessed by two people. So if he is willing to have that conversation there in the office, I don't know if you have a notary or not. If you do, great. If not, right, like it needs to be witnessed by two people. It can't be you as the attending physician, is kind of all verified. And that statement of, sound mind and not being coerced in the conversation. Again, this can be witnessed by people in the community. So we don't, if he has a reasonable understanding of the role of a power of attorney, can explain who he would choose and how that would benefit him, would encourage to get that completed.
Rather that than the guardianship, and it doesn't sound like he's at that level right now from what you're describing civilly. And you don't want to have him come to a probate court. That's a whole nother layer of mess that he's going to have to deal with the language and all of that, or whoever's the guardian. So less restrictive is much better.
Understood. Thank you, Laurie.
Just a thought, right? Like I think that the cancer center here, has some support. They always have care managers, social workers. I think they have some support groups also. But I imagine that's something that is probably very culturally nuanced. And so I would, is that an opportunity within the populations you guys serve? If it's within the International Institute, correct me if that's the incorrect language, is there an opportunity to build some of that? I don't know.
I will look into that. I saw what's her name? I remember her last name is Bishop. She's a really great social worker. But she has been really busy. I see that she's trying to get grant and she's trying to get loan, and then all the DMEs and all the supplies. I don't think she has time to discuss that yet. And then also I think she actually think the patient's cousins or friend is his brother, because that's how they call themselves, and then how the patients would call him too. But I will talk to my staff and let the social worker know.
All right, well, thank you very much for presenting today this very interesting case, and thank you everybody for participating in this discussion. So I think you can see, for those of you who are here for the first time, it's not always just about the medicine, and you guys know that from your own background. So, and the benefit that can be gained by having multiple perspectives contribute to the discussion also. So that's our goal here. So thank you for being here and for participating, and we will see you later. Thanks.
Bye.
Thank you.